Thank you, ma'am. Thank you. Thank you, ma'am, for those kind words. And thank you, Nisha. And thank you, Shrutika, and everyone else.
Let me tell you, Siddharth, you've already got 235 participants.
Because it's the first one, I think. Actually, I must tell all the participants this is a wonderful program run by Dr. Anita Bojas and Sumit Gujral with a nice team they have. And let me tell you, of course, this is not compulsory, or this is not going to replace your usual pathology that you're learning or practicing, but definitely this is going to augment your understanding, and you get to interact with people all over the world. And it's really wonderful how they have done this. I've been there right from the first one, and the first talk, of course, was on terminologies and patterns in pathology right from beginning, and we're repeating it. So sit back and let's start with this. Well, there are certain disclaimers even from my side. It's for teaching and compiled as usual from experience, textbooks, and journals and authors who we have acknowledged, and there's no financial interest or conflict of interest to declare, and none of us get paid for these talks. Well, all of you know what this is. That's pathology for you in Greek and Latin. Now, let's say a medical student when wants to take a post graduation should be either crazy or sane. Then, if he's crazy, it depends on his attention span. If it is significant, then of course he takes up psychiatry. If it is non-existent, he has to take up emergency medicine. Well, if he's sane, it depends whether he's hardworking or yeah. So it depends whether he's hardworking, and if he's not so much hardworking, then it depends whether he's afraid of the light or the dark. If he's afraid of light, then he takes up radiology. If he's afraid of darkness and he thinks big, he takes dermatology. If he thinks small, he takes up ophthalmology. If he's very hardworking, depends on his attitude. If it is nice or mean, or doesn't matter. He's mean, he takes up surgery. Nice, if he hates adults, he takes pediatrics, he or she, and hates children, then it's medicine. It doesn't matter if the patient is asleep, takes up anesthesia. If he's dead, apparently takes up pathology. But this was given to me this by a psychiatrist. But let me tell you, nowadays, when I ask some of my students, why did you take up pathology? Well, the system now is such that it's very difficult, and often they tell me that this is what I got. But anyway, if you have taken pathology, you can sit and enjoy. It's one of the best subjects that you have got. You can enjoy, and it's something you will learn about so many diseases, from lichen planus to glioblastoma multiforme. There's hardly any branch that deals with all the known diseases that human beings. Well, this is pathology for you. Comes from pathos and logia. And the problem is, many of these terminologies will be new to you when you join this, when you join pathology. We are here to decipher some of them. For example, you just see it's X and L, it's Latin, they're consonants. If the Roman, it's 40. And well, if you go to a garment shop, it's the size of the garment. So things mean different in different contexts. So some of the terms that we use. So once you keep learning the subject, you'll automatically learn the words. It's not very difficult. The general way that we diagnose, there are 2 or 3 ways that all of us use for diagnosis. One, for example, a clinician finds a person with fever and dysuria. He thinks it must be an urinary tract infection, and the commonest is a gram-negative bacteria. He gives an appropriate antibiotic, and if he is cured, of course, it explains the clinical situation as well as the diagnosis. Even sometimes the patient becomes better by the time the culture and sensitivity report comes. So this is what is called a payoff. We often make a diagnosis. Sometimes people call this a gut feeling and so on and so forth, but it's generally not gut feeling. It's the result of a lot of experience, right? Now, the other way is, suppose there's a granuloma which and it's AFB negative. It's tuberculosis in our country. That's the most common diagnosis. Put him on ATT, whether the AFB is positive or not, whether the culture is positive or not. And if it does well, your diagnosis stands and you're vindicated. So these are the payoff systems that you do. And of course, if you have a culture and all, that's the best thing. The other way is, especially during learning, you're finding, is this a granuloma? Yes, it does look like a granuloma. It's almost like a yes, no. Is this granuloma caseating or not, confluent or not? Ah, yes, this granuloma is not caseating, but I searched elsewhere and there's a granuloma that is caseating. That's great. So is there an AFB? Let's do an AFB stain. Might be tuberculosis. You have a list of differential diagnoses. You do an AFB stain, AFB is positive. Ah, yes, since AFB is positive, this must be tuberculosis. So this is the way that we go on, and this is the heuristic analysis, a goal-seeking process. This yes-no is very good while learning in your initial stages, and after some time it happens at the back of your mind. You don't have to ask these questions, and then by that time, by seeing many slides, certain patterns are imprinted in your mind. Initially, while you compare the pattern in the slide with that in a WHO fascicle or some other textbook, after some time, all those pictures are in your mind, and your brain matches them so fast that after some time it becomes spinal level for some diseases. But invariably, there'll be tough ones, and you'll have to use the heuristic analysis. But what is essential is you must do a clinical pathological correlation, and it's better to see slides on your own, make an impression, and then try to go back and see if you can explain the clinical yes, features. And you look at the form, and if it matches, it's a wonderful feeling, and you know that your diagnosis is within 2 or 3 possible differential diagnoses. And this is the way, if you do, you learn a lot. That's the most important. So let's see the words that we use. First, I think, let's see this. Can I put it down? Okay. The word active. You see, the slides that we see includes fixed cells that are neatly framed, actually, and it's a snapshot at one time in whatever the lesion is undergoing. And this is at high speed. So let's see. This is almost like you're seeing the water droplet just falling into the pond. So dynamic terms such as activity are supposed to be logically incorrect, although these are implied whenever you use them. In non-neoplastic lesions, you have piecemeal necrosis in the liver, which is used as active hepatitis, proliferation and neutrophils in glomerulus, which is called active glomerular nephritis, neutrophils in colonic crypts and crypt abscesses is called active colitis. So you use terms like active in such non-neoplastic conditions. Neoplastic lesions, sometimes they are referred to as tumors that are proliferating with a lot of mitosis, and in fact, mitotic activity is often used synonymously with the so-called mitotic index, but it's better to indicate the number of mitosis per unit area, and you know that is done in breast and other cancers. So there is a case for restricting its use and replacing by more very descriptive terms. So this is an active hepatitis, piecemeal necrosis there, active colitis, and an active neoplastic lesion with mitosis here and there, 1, 2, 3, easily, which can be seen. Okay, so next we come to another thing with the adenoid cystic. It's seen in several tumors, especially salivary gland tumors. It almost looks like cribriform, but one has to know that adenoid cystic carcinomas have two types of cells, the myoepithelial cells and the smaller epithelial cells. And the cribriform carcinoma is made up of monomorphic epithelial cells without myoepithelial cells. So this would be the two different examples of a cribriform carcinoma and an adenoid cystic. Now we'll see these adenoid cystic spaces are actually myoepithelial line spaces which are not glandular spaces but invaginations of the stroma that gives the appearance as if it's the inside of a gland. Now look at this area. You see the stroma is going inside here, and this is actually a double layered, almost like a tubule that has been compressed by the stroma. So if you look at the edge of an adenoid cystic carcinoma, you will find the stroma entering into these areas, and these are cut sections of the similar areas, and they look almost as if this is a gland with a secretion and a cribriform appearance. But closely, if you see, they are bilayered. It's almost like a tubule that's been compressed. Okay, here also you see this. This is how you make out an adenoid cystic. This is another area. So nicely, the stroma is inside, and you find this almost like a tubule, two layers of cells. Of course, you have immunohistochemistry and other things. This is cribriform, purely epithelial cells with a real lumen in between, almost punched out holes that you're finding here. That's a lumen here, and this is a cribriform. So next to come to anaplasia, another thing with it. Anaplasia means reverting to a more primitive or less differentiated form. Ana means reversion, and placine is to form. Undifferentiated means lack of differentiation. It hasn't gone back. It is there at that stage. It is lacks any differentiation or similarity to the differentiated cells. So if this person goes back, that would be an anaplasia. And if he's undifferentiated right throughout, he would be undifferentiated, right? So if a final year MD student goes back to a form that's similar to a first MBBS student, he has undergone an anaplasia. But if he's like this throughout, then he hasn't differentiated, so he or she is undifferentiated. Well, this is how it is. So see these, but they almost look alike, this anaplastic and undifferentiated tumor. But for the sake of understanding, you must know that the terms, although they're used interchangeably, anaplasia is best restricted to nuclear changes. Tumor which is hyperchromatic, close with a coarse clumped chromatin and irregular nucleoli is best called anaplastic, whereas differentiation you use for cytoplasmic features. So small cell carcinoma of the lung would qualify for an anaplastic carcinoma, but not an undifferentiated tumor. On the other hand, if you see Wilms tumor, the anaplastic Wilms is based purely on nuclear features. So you have this multipolar polypoid mitotic figures with nuclear enlargement and hyperchromasia. So anaplasia best kept for nuclear and differentiation for cytoplasmic features. Well, see this, what would you call this? Because of the nuclear features, although there's some cytoplasm, this would be anaplastic, right? And in the case of thyroid, you have a poorly differentiated thyroid carcinoma and one that's called undifferentiated and anaplastic thyroid carcinoma. In the poorly differentiated form, you have here is the immunohistochemistry that helps, although they may look somewhat alike. There's diffuse nuclear positivity for TTF1 and dot-like for thyroglobulin. Whereas for the undifferentiated, TTF1 is negative and the thyroglobulin is also negative. So this indicates this undifferentiated anaplastic type is more primitive. Next with A, we come to Azzopardi effect or phenomenon, described by John Azzopardi. He's a very famous breast pathologist also. Described it in lung tumors, where you get a smudgy blue appearance, especially in the necrotic areas, and they are in the wall of blood vessels. And these are characteristically described in lung carcinomas. You can see it in other conditions. This is nothing but smudged DNA. Similar to this, but not the same, is the hematoxylin bodies or hematoxylin bodies. That's the right term. This is seen in lupus. This is smudgy DNA in the nucleus. You can't see them in the renal epithelial cells sometimes in case of lupus nephritis, but they are very rare. In fact, one of my teachers who was a stalwart in renal pathology, he said that if anybody has seen an hematoxylin body of Gross, he has seen God himself. So it was that rare apparently at that time. But you do see them. Sometimes you see them in the spleen also. Then hemianthoid bodies. These hemianthoid bodies, they are pink, brightly pink. The central part is more dark, eosinophilic. The periphery is light. They are composed of two types of collagen, type 3 and type 1. Invariably, you may find a blood vessel in the middle. And this is seen in the intranodal palisaded myofibroblastoma. That's the classic one. But people have described in smooth muscle tumors of the uterus, in neurilemomas, schwannomas, and so on and so forth. But classically seen in intranodal palisaded myofibroblastoma. It comes from the word similar to amianthus, and that's a Greek word for undefiled, and it's used for a type of parachrysotile, which is used for asbestos. And they are of blue, green, yellow, and red color, and some of them have this beautiful pink color. The amaranthus fruit that you see has this color. It's a rosy pink color, and perhaps it's because of this. And the fibers are very fine. Some of the asbestos fibers are very fine. And coming to asbestos, I think there's something else you should know. In asbestos, you get ferruginous bodies and nothing but asbestos fibers encrusted with hemosiderin and ferritin. And in fact, it's said that it's most probably these are iron-encrusted bodies which are engulfed by macrophages, and they have iron. You can do a Pearl stain. So this is a ferruginous body. This is with F, but I think in thyroid body. Now B is for balloon cells. Balloon cells are nothing but large distended cells. Invariably, they're somewhat clear. Balloon cells are usually clear. In many of the non-neoplastic conditions, like in the liver, these balloon cells are nothing but hydropic change. The sodium pump doesn't work. The water gushes in, and so the water salts and water is retained, so they become large, right? But you can get balloon cell nevus, clear cell carcinomas, sarcomas, where the cells are ballooned, and so on. So blastoma means it comes from the word blastus, a sprout, a germ, and they indicate very, very undifferentiated cells which are very primitive, formed like germ cells and so on and so forth. You have various blastomas, right? Then you have columnar and cuboidal. Columnar cells, the height is more than the breadth, and in cuboidal, like a cube, almost all the six sides are of similar size. Okay, so columnar is like a common, this column, and cuboidal is like a cube. So you have columnar epithelium. This is in the endocervix, and this is the cuboidal epithelium, right? So you have this cribriform. Cribriform, you have these little spaces among sheets of cells, and it comes from the word cribrum or sieve. You have almost uniform spaces here, and it's and these are generally found in carcinomas of the breast, prostate, colon, endometrium, and other sites. You must distinguish this from adenoid cystic carcinoma and col bodies, and sometimes glands which are arranged almost back to back with hardly any epithelium nearby in between. Okay, so that's how it is. Okay, some people are asking that I should use the laser pointer. Okay, can you see this? I'm sorry. Right, so this is the sieve, and that's what you can see. Okay, so it won't go till I push it off. That's the problem. Next, we come to Call Exner bodies described by Lewis Call and Sigmund Exner. Right? You see, here also you see spaces within eosinophilic material and nuclei almost arranged perpendicular. Sometimes you do find grooves in these nuclei. Right? So this is the typical Call Exner body, and find them in certain tumors, which of course you learn when you do gynec path. Well, now then you have Swiss cheese pattern. Swiss cheese patterns. All those who have read Tom and Jerry comics will know that this is nothing but this characteristic of certain cheese found in Switzerland, where you have these holes because of the gas bubbles there during the processing of cheese, and you find various holes in between of varying sizes. And the typical one is seen in the endometrium, where you have Swiss cheese endometrium, and these are lined by epithelial cells. Right, so this is Swiss cheese for you. If they're almost uniform and more distributed, you call it honeycomb, and common is the honeycomb lung. So this is the honeycomb, and you find this honeycomb lung, which is seen in numerous different end-stage lung disease, and you find this typical wider spaces, almost uniform distributed. Cobblestone appearance. Cob means rounded by water. Stones which are rounded by water. These stones were used to pave a path, right? And so you have a cobblestone path. What you see are these stones, and in between you're seeing a depressed area. That's the ground there. So this is what is seen typically in Crohn's disease. These raised inflamed areas with depressed areas, which is the unaffected places, and this gives rise to what is called a cobblestone appearance. Right, so you can see them even on endoscopy. Cluster, nest, and nidus are almost similar. It indicates a small group of cells, like a bunch of keys, or a nest, like a small bird's nest. So you can call a cluster of cells, right? Or you can nidus, which is seen in osteoid osteoma, osteoblastoma, right? And this term is used even by radiologists, right? So see this in osteoid osteoma and osteoblastoma. Then you come to crypt. Crypt are very deep structures, and this is in the church also. You'll find uh, deeper portions, right, much below basement level 2 or 3, in fact, which are called the crypts in church, and that's where they used to bury the dead. And it's called. And you must have seen horror movies called Tales of the Crypt and so on. The ghosts would come out from there. So these are very deep openings. You have an opening mouth and then a very deep opening. On the other hand, if they are shallow, you call it a pit. Like in the stomach, it's called a gastric pit. So pit is a small, shallow opening. It's a small hole-like thing that you make on the ground, where a crypt is something which is deep, as you see in the colon, normal colon. Then bosselated. You use the term bosselated when for something on the surface. It's not on cut section. So on the surface, when you have large protrusions, they should be large. Is there a size cutoff? No, there isn't a size cutoff, but visually it should be large. That's why you have, it comes from the French word bosse or boss, which is boss means a real boss, so it's a large, fairly large raised areas that gives an uneven surface texture, almost like an embossed text, which projects from the surface and is very prominent. Okay, so that is how you use the word bossylated for gross around the surface. On the other hand, you use the term nodule. Nodule, the word nodule comes from a knot. So you use a nodule or nodular appearance when there are small rounded areas which are look more or less separated from each other. They are individual. Usually they're separated by the intervening tissue or connective tissue. And in the kidney, nodular lesions are seen typically in diabetes, glomerulosclerosis, and it refers to this material in the mesangium. It's not in between the cells or in the capillaries. Then you don't use the term nodular in the kidney. Okay, so this is a nodular lymphoma, and these are nodules in an adenomatous goiter of the thyroid. So nodules can be seen in the cut section also. Okay? Lobulated is somewhat like what you see in a clover leaf. There's a central area with these leaf-like, and if you see, the surface is always smooth, and so you can use lobulated, especially not only in microscopy but in the gross also. In whenever you you see a gross tumor in which this could be termed as a lobulated surface. This is smaller than a bossulated. Okay, so if you ask, is there a cutoff? These are quite a high part of the lung where these are smaller, and these seem as if it's connected in one place and with these clover leaf-like things. Unlike nodular, which looks completely separate. For example, a metastatic lesion, you'll call it has multiple nodules, rounded lesions elsewhere. Right? This is a lobulated lesion in the kidney called lobular accentuation in a case of membranoproliferative glomerulonephritis. Here you're not going to use nodular, and please note it looks like the glomerulus is attached here with these lobules being accentuated. Okay, so that's how you use the term, different terms, lobulate, nodular. Now here granulomas are actually nodular, and granulomas could be discrete, which means separated from each other, or it could be confluent, when here it looks like two granulomas attached to each other. So you use confluent nodules when they seem to attach to each other. It comes from the word confluence, or flowing together. Or separate, then you call it discrete. Dysplasia generally used to denote a precancerous or potentially cancerous change, but it was also used for certain developmental abnormality. But by and large, for example, fibrocystic disease was once called mammary dysplasia. It's obsolete, and it's more commonly a precancerous change with nuclear changes and so on and so forth. Very commonly used in the cervix, for example. Okay, and atypical hyperplasia, carcinoma in situ, intraepithelial neoplasia are more or less used synonymously. Although currently intraepithelial neoplasia lesions are more in vogue than the other ones. Okay, but dysplasia is still used in the colon, cervix, in melanocyte, dysplastic nevus, and in the bone marrow. Whereas atypical hyperplasia is used in the urogenital tract, endometrium, and urothelium. ATPI is used in vulva and respiratory tract, carcinoma situ especially in the breast, and intraepithelial neoplasia in various areas, including in the endometrium and so on and so forth, cervix. So by and large, they mean almost the same thing. So this was what was called mammary dysplasia earlier. You also have renal dysplasia. You have fibrous dysplasia of the bone, which are not at all neoplastic in that sense. Okay, they are not precancerous. Of course, fibrous dysplasia, long-standing and known to cause result in osteosarcoma, but you wouldn't worry unlike a dysplasia of the cervix or something like that. Okay, so these are the dysplastic lesions, this fibrous dysplasia. These are the breast, you see. Okay, then the term dystrophy. Dystrophy is originally used for faulty nutrition. Dys and trophy. Trophic is nutrition. Now they are used in different connotations. They mean different things in different areas. For example, vulvar dystrophy, it has inflammatory changes and nothing to do with a condition that is known as muscular dystrophy. In muscular dystrophy, the muscle cells are small, as if they lack nutrition, and of course we know this could be a Duchenne's or Becker's or spinomuscular atrophy, so on and so forth, where the fibers are atrophied. There, the term dystrophy is used in a different context. Most of them are they are congenital; they have a genetic basis, unlike vulvar dystrophy. Right? So epithelium. Epithelium means upon the nipple. Actually, Ruish was studying the circumvallate papillae in the tongue, and you see these papillae look almost like a nipple, and it found squamous cells which are on top of these, lining those nipple-like projections in the tongue, and he called it that is epithelium. Those cells are epithelium. Epi above, thelium, nipple. Then Henle later on adopted Henle, the loop of Henle. Same gentleman, he adopted this for all types of lining cells, and that's how it is. So this is the epithelium in the circumvallate papillae. Fibrinoid necrosis. Fibrinoid necrosis is not a necrosis. I put it here because EF. So put it here because this will tell you it's actually fibrin deposition, and it's seen in a variety of autoimmune conditions. So fibrin deposition is often called fibrinoid necrosis in certain conditions. Okay. Then fibrosis. Fibrosis, you have fibrosis. In fibrosis, we use the word desmoplasia. Desmos means to restrain, and plasis means forming. It restrains the cells from going anywhere. So that is the desmoplastic tumor. For example, this kind of fibrosis in between the small tumor cells is typical of DSR, CT, or desmoplastic small round cell tumor, and intraabdominal, predominantly intraabdominal tumor. You can see it anyway. Similarly, there may be tumors with a lot of fibrosis called desmoplastic melanoma is one example. Tumor that's almost composed of fibrous tissue. That's a desmoid tumor for you. Okay, so these are the examples where you can use the word desmoplasia. The other words that you use in a similar context is sclerosis. Use the word sclerosis when grossly it is hard, and often this has been used even microscopically, but it was originally from a gross term which meant hard. For example, a sclerosing tumor actually meant a hard tumor, and similarly a hard or swelling or tumor was also called scirrhus, and it comes from the word callus or a hard tumor, and many people use the term scirrhus carcinoma of the breast, although it should be restricted to gross. Many people now it's not used at all. Earlier people used to use. So all we know, they are all invasive ductal carcinoma with various extent of fibrosis, right? Okay, you can see it in gross and in radiology. You have sclerosing hepatocellular carcinoma. Fibrosis is also used in the bone marrow, call it bone marrow fibrosis. Use pulmonary fibrosis and fibromatosis. We don't use bone marrow desmoid or scirrhus bone marrow or scirrhus lung, or there we use the term fibrosis. Keloid. Now, keloid is taken from the word sansroid, or it's almost, it was later changed to keloid because it meant crab-like, which was used for cancer. It used to hold the tissues, and it had the gross appearance almost like a crab or crab pincers, and that's why he likened it to the cancer. He called it canceroid, but then it was changed to keloid. Okay, keloid, of course, is another example where you have almost hyalinized collagen forming these lesion. Then elastosis is whenever the elastic tissue is increased. The elastic tissue typically is seen in blood vessels and in the skin, where you have to have a recoil in the blood vessels with every beat, especially in the larger blood vessels, aorta and so on. So you get duplication of this elastic tissue in hypertension, what's called benign elastosis. For example, in the skin, you can have degeneration of the elastic tissue, pseudoxanthoma elasticum, and so on. So elastic tissue is generally stained, but you can't see them, unlike collagen, which is more pink, and you can even do a birefringence. There are special stains for different types of these fibers. For elastic tissue, Van Giesen or Vera Van Giesen or Orsine stain. Then what's the difference between ectopic and heterotopic? Sometimes people confuse. Ectopic means away from a place or out of the way or out different place. Whenever an organ is ectopic, that means organ or tissue is ectopic, that means it is located at a place away from its normal conventional location, and in that normal location the tissue is not present. For example, if you have an ectopic thyroid in the tongue, base of the tongue actually, or near the larynx, that means the thyroid tissue is present here and there's nothing in the neck, then you call it ectopic, right? So your ectopic testis means it is present somewhere inside the abdomen, it's not present in the scrotum, right? So that is what is called ectopic, not present in its original position but present elsewhere. Invariably it is along the line of development. Heterotopic, on the other hand, this is heterotopic gastric mucosa in the duodenum. So it means that the tissue, there is another tissue there, heterotopic tissue, and so therefore in the duodenum there is another tissue, that is the gastric tissue. In heterotopic gastric mucosa here, or gastric glands, it means these gastric glands are present in the duodenum. It's also present in the stomach, which is its original position. Heterotopic gastric mucosa in Meckel's diverticulum means there is gastric mucosa in the Meckel's diverticulum as also in its normal position. Suppose there was no stomach and it was all in the Meckel's diverticulum, you would call it ectopic gastric mucosa in Meckel's diverticulum, right? Some people sometimes get confused and use this synonymously, but this is what the original and the right meaning is: ectopic and heterotopic. Giant cells. Now, giant cells are large cells. There is no size cutoff, but generally 40 microns. That is about 5 times the size of a normal RBCs, or a little larger than that, 5 or 6 times. And it is generally because of similar cells fusing together, what's called homotypic cell fusion, maybe heterotypic cell fusion also. So now you have certain large cells, which could be called giant cells, which are normally present, or physiological or in pathological condition. The physiological ones are osteoclast, syncytiotrophoblast, and megakaryocyte. Osteoclast, of course, they are characterized by multiple nuclei and a fairly nice cytoplasm, and syncytiotrophoblast present in the placenta and megakaryocyte. Well, how many nuclei do megakaryocytes have? Can anyone just answer in the chat box? I'll give 5 seconds. You just have to write the number. Kritika?
Yes, sir.
Sorry.
Yes, sir.
Anyone, both of you, have they written?
Yes, sir.
What are they writing?
1 nuclei, 3 to 5, 8, 1, more
Okay,
than 3, 5
actually
to
it's only
6.
one nucleus. As the megakaryocyte grows in size, it replicates its DNA without the cells dividing. It's a nuclear DNA increase without, and as a result, the nucleus becomes very large and convoluted and obulated. And in our sections and smears, they look as if they are made up of multiple nuclei. In fact, the megakaryocyte DNA complement can be 64 and 32 copies of the normal complement of. Okay, now pathological, inflammatory, we have the foreign body giant cell, right? You have the foreign body giant cell, less nuclei, but you'll find a foreign body. Langerhans giant cell, where they are found in the form of a wreath. Anishkov cell, it's almost like a caterpillar here. Aschoff cell is different from the Anishkov's myocyte. Two-tone cell, where you have cytoplasm, a ring of nucleus, and again cytoplasm is generally foamy. Anybody can tell what this cell is? Anyone? Has anyone written?
Not yet, sir.
Okay. 1, 2, 3, 4, 5. Okay. Right. This is called
Crouton cell.
the crouton cell.
Crouton cells, they are writing, sir.
Oh, good, 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 good. Crouton giant cells. Where is it seen?
Warthin, somebody has written. Warthin has written, sir. Lung,
Crouton giant cells.
lung, cryptococcus,
Yes, it's
cryptococcus.
seen in
cryptococcus.
cryptococcus.
Yeah.
Good. Then in viral infections, right, you can get the herpes giant cells, large faded nuclei, cytomegalovirus, right? In cytomegalovirus, of course, you have a nucleus with, you see this large intranuclear inclusion. You can also have cytoplasmic inclusion. The cell should be large, predominantly seen in endothelial cells. And generally, if this inclusion occupies more than 3/4 or 75% of the nucleus, you can be dead sure in cytomegalovirus. Warthin-Finkelty giant cells, you get dark nuclei multiple in measles, and of course, respiratory syncytial virus also, you get these giant cells. So these are the viral infections where you get. In tumors, of course, osteoclastoma, Reed-Sternberg cell, anaplastic tumor giant cell, rhabdomyoblast. Generally, in tumor giant cells, except in say osteoclastoma, the nuclear cytoplasmic ratio is high. Less nuclei, but the nucleus occupies almost the entire cell. That's what you see. Others, you have neonatal giant cell hepatitis. Usually they have 3 or more nuclei, not 2. Okay, 2 nuclei in a liver cell can mean regeneration. So 3 or more, and you have this muscle giant cells, which you see in a variety of conditions. You have some inclusions in the giant cell, which includes asteroid body, which looks like star-like inclusions, which you find in sarcoidosis, Schaumann body, but these are not that specific, although they're commonly seen in that. You may find oxalate crystals, cholesterol crystals, and those of you who are interested in hematopathology will find this Hamazaki-Wiesenberg bodies. Okay, right? These are some of the inclusions that is. Glandular. The word glandular comes from glans or acorn, and you see it looks almost like the glans, normal glans penis. So the word glans penis also is from that, and you have gallans, gallandis, acorn, and the reason why the glands secrete and acorns also literally fall off from the tree. So it is cast down or it is dropped. So that's what they said it was the glands. Now the word glandular, we'll come to that. Adenocarcinoma encompasses all types of glandular configuration. They could be tubal, ductal, acinar, or follicular, depending on the cell of origin. Okay? And while you see, if you see some secretory, it could be acinar in origin, but very often you don't get anything, you just get spaces. And there, no, more than the morphology, conventionally, whatever is there, you call. Now, this tubular is used when there's a long tube, like gland. It is assumed that these are tubular glands, they have a very long opening, right? Lobular or acinar is, they are made up of lobules connected to a central place, and then you have these individual lobules, almost like a bunch of grapes, right? So, or berries, So you have in the pancreas lobules, you have in the breast the terminal duct lobular units, and so on, so on. And by convention, anything that arises from the, for example, in the breast, you call it a lobular carcinoma of the breast, and so on, so forth. The word ductal or follicular comes from bellows, and what you will find is in the bellows, the opening. This is the place where you press, and the air is generated, and it comes out to a very narrow opening. So when you don't see the opening, you generally call it a duct or a follicle, right? For example, in the thyroid, we know that this colloid, this secretion goes out, but because it's presumed there is a duct there, you can't see. It's like a follicle. It's called a thyroid follicle, right? There's a hair follicle, very thin opening outside, and in the breast also. So you, unlike in the breast where you find a very nice duct going out, right? So in the lymph node also, they are called follicle because it was believed these follicles secreted the immunoglobulins and other things, and therefore that would go out, right? So use the term follicle. Alveolar, when there's a wide opening, a receptacle, and that's used in the lung. Alveolar soft part sarcoma, which is the picture here, right? So this is the alveolar soft part sarcoma, right? So then that's when you use alveolus. Okay? So the gland that you have are tubular, acinar, alveolar. Then you have merocrine glands. Merocrine glands are those, they have the secretion which goes out. Then apocrine. When the apocrine gland, the secretion reaches the surface, it takes a nubbin of a little bit of cell material around it. So you have this little bit of projections on the surface when they are just going out. And holocrine is when the entire gland dissolves out, as in the secretion appear and the entire gland breaks, as in the sebaceous glands. That's holocrine. So you have merocrine, apocrine, and holocrine. So this would be apocrine, and the others, one will be merocrine, and the sebaceous glands are holocrine. Okay. Now then focal. Focal comes from focus, heat, or fireplace. That's the central area where the entire family used to sit. So focal means a point of convergence, right? So you have focal or patchy chronic inflammation, inflammatory bowel disease. So focal increase or patchy. You have focal glomerulonephritis, in contradistinction to diffuse glomerulonephritis. And there, of course, in the kidney, you use global if the entire glomerulus is affected, and segmental when a part of the glomerulus is affected. Granuloma comes from granule or a small grain, right? So hemangiopericytoma or hemangiopericytomatous or hemangiopericytoma-like pattern are characterized by thin walls, thin wall vessels that have a stag horn or antler-shaped nucleus. And there are various conditions where you get, which I have mentioned here. Okay. If there is just a collar of cells surrounding the blood vessels, you call it perithelial or peritheliumatous appearance, and that refers to the cells, not to the shape of the blood vessels. So this is the stag horn or antler stag horn of the antlers, and similar shape you can get in which will which are called hemangiopericytomatous appearance. This would be perithelial arrangement of vessel of cells around the vessel, and this is the hemangiopericytomatous pattern. Okay, it's very important that you see this diagram. Hobnail. Hobnail are those nails which people used to put under the boots so that you get a nice click, especially while saluting or standing in attention, or they are often used in many other, just generally people walking on streets. So you have a large head and small body. So this is the hobnail appearance. Please note, the nucleus is generally towards the lumen in a hobnail nucleus appearance, and it's a large one in which you almost can make out a head which is wider and a thinner body here. That is hobnail, and it's fairly tall. This is unlike the apocrine which I showed earlier. Okay, lacuna. The word lacuna means blank or missing portion in or it can mean a hole or a pit, and therefore you have lacuna in the bone. You have lacuna cells which are nothing but retraction artifacts in in a Hodgkin's lymphoma. This is the lacuna Hodgkin cells, and you find a space in which these cells are the lacuna. You have a lacunar infarct also, and that was a gross appearance. Now they detect it in CT. Microscopically, there's loss of brain tissue here. The small area seen in hypotensives mainly. Okay, and this was described by autopsies by Amédée Deschambre, and 5 years later by Maxime Durand-Fadel, who was a neurologist. Medullary. Medullary comes from soft, or generally it indicates marrow. It's a gross term, but nowadays it's used for intermediate malignancy. So medullary carcinoma, thyroid, breast, and originally it meant a soft tumor. These are, of course, nuclei with empty spaces. In the thyroid, they're called orphanine nucleus. In the liver, they're called glycogenated nucleus. So glycogenated nucleus is seen in the liver in diabetics, non-alcoholic fatty liver disease, Wilson's disease, and so on and so forth. This is the orphanine nucleus, typically seen in papillary carcinoma of the thyroid. So two different places, similar thing. And Orphan Annie was a cartoon character. She had a nice little dog, and both of them had rounded eyes, according to the artist, without any pupil in the middle. So that's why you have this Orphan Annie. This is a cartoon character in the US. I don't know if the cartoon still exists in the newspapers, right? Papillary. Papillary means there is a fibrovascular core with cells. It means actually a swelling nipple or teat, and you can have renal papilla taste buds, skin also. And papillomatosis indicates a finger-like configuration, generally over a fibrovascular core. But the cores may be absent in introductal papillomatosis, and there actually micropapillary or epitheliosis is a better term to be used. So you see, this is different, where you have a stroma also, in a villi. This is just a fibropapillary core in a transitional cell, papillary transitional cell lesion. This is in the skin and these are in the breast. There's no fibrovascular core. So many say that it's better to use micropapillary epitheliosis for such lesion. Pearls, pearls. All of you know these pearls are seen in squamous cell carcinoma, and indeed they look like pearls. Perineural invasion is actually perineural lymphatic invasion. There's no lymphatic actually. It's actually a perineural space around which the tumor spreads. Typical of prostate and adenoid cystic carcinoma. Right. Phyllodes. Phyllodes means leaf-like, and you see these are typically leaf-like configurations seen in the lesion called Phyllodes tumor, what was earlier called cystosarcoma phyllodes. Phyllide, some people. Physalliferous means bubble-like, typically seen in chordoma. So they're large bubble-like appearance of cells. Okay, and samoma bodies means grains of sand-like. And then of course you find these calcific bodies which are seen in various conditions, and they generally have a concentric layer around them. Typically seen in meningiomas, in certain tumors of the ovary. Right, samomatosis. Reticula means net-like, fish net-like. So you see it in various conditions, and plexiform is also net-like, but it's not used synonymously. Roman bridge. Roman bridges are, this is the typical Roman bridge in which you have rigid pillars here and a rounded opening for the water to flow through, and there's a bridge where it's thin here. And these Roman bridge appearances are typically seen in in intraductal carcinomas of the breast. Rosettes. Rosettes are rose-like. They are commemorative. You can see it in the church. And then there are different kinds of rosettes. Some have central lumen. They are called Bailey's true rosettes. Flexner's or Flexner Winstina rosettes with an empty lumen, an epidermal rosette which contains cilia. So there are two with the central lumen, and there are two which don't have distinct lumen. Homerite or neuroblastoma rosette have a tangle of neurites in the middle, and perivascular or glial vascular rosette seen in astrocytic and ependymal tumors. Now these two are also called pseudorosettes, right? Those which do not have a distinct lumen are also called pseudorosette. But the term pseudorosette is best avoided, and you call them by their proper name: true rosette, pseudorosette. Pseudorosette may have a vessel. So ependymal rosette, flexner, intestinal rosettes, and homerite rosettes, right? So these are the different types of rosettes that you see when you do neuropathology. You learn more about these. There are other things. You can get rosettes in neuroendocrine tumors, where you have a central lumen with the nucleus pointing away from this lumen. You can get in various neuroendocrine tumors. In the liver, you can get a cholestatic rosette with cholestasis or a canaliculus in the middle, or a hepatitic rosette where there's no space, full of hepatocytes, seen in autoimmune other inflammatory conditions. So these are the rosettes. Schiller-Duval bodies, described by Walter Schiller and Matthias Mary Duval. So they are generally like a glomerulus almost. You have a blood vessel in the middle with cells all around, right? Right. So this is typically seen in the endodermal sinus of rat during the normal development, and this has been likened and seen in many of the yolk sac tumors of human beings. Right, they mimic the endodermal sinus of the developing rat. Okay, and this is different from a glomeruli body. So in a glomerulus, you not only have epithelial cells in this, you also have mesangial cells there. Okay, so these are the parts. You have an allantoic vessel in the middle, the yolk sac, endoderm, and a labyrinth, which is the space all around. Signet ring cells, they have an eccentric hypochromatic nucleus with round clear cells which represents a ring. They may have certain intracellular mucins. On the other hand, the colloid carcinomas have abundant extracellular mucin. Signet ring carcinomas have got intracellular mucin, and colloid carcinomas have extracellular mucin. Muciphages are macrophages that have taken up. Now, the word signet ring, many say they are wedding rings. They are not wedding rings. It is a ring of the king, which had the insignia of the kingdom, and on the wax he used to just put his seal of the kingdom, or that was a signature or signa. That's why it's called the signet ring, and that is why these rings are called signet rings. They have nothing to do with the wedding. Many people say it's wedding ring, and this is how it is. Okay. So spindle is of course used for in weaving clothes and getting these threads on. So it has pointed ends. One end may be more pointed than the other. So these are spindle cell nuclei, spindle cell nucleus. Some in the nucleus in neural tumors are not only spindly but they're wavy. Okay. So fascicle. Fascicle is nothing but like you see you have an fascicle. They are a bunch of books together. Fascicle means a bunch together. You see these tumor cells, the sarcoma with these mesenchymal cells which are spindly arranged in a fascicle or a bunch like this, almost streaming across. So that's the time when you use fascicular arrangement of cells. Right? Storiform. Storiform is derived from story or matting. The end of a mat, you see, they're round. They almost include whirligig, spoke wheel, pinwheel, spiral, nebula, all kinds of world appearance. Okay, it's not diagnostic of any condition, although they are most commonly seen in dermatofibromas PFSPs. So this is the storiform pattern that you see in the end of the wheel. The best way to remember, these are the different patterns you can get, almost like the fingerprint and so on and so forth. Best way to remember is this is the cowlick at the back of the hair. Best seen in boys, you can get these are three storiform patterns, three cowlicks. They're called cowlicks because the tongue of a cow, when it moves like this, it gives this pattern. So this is a typical storiform pattern for you, right? So in case the boy next to you can see the back and you find. So these are the different storiform patterns. Okay, so that you see in different humans. Herringbone. This is a herring fish, and they have typically very nice fine bones which are parallel from the spine. And the herringbone pattern was described in many tumors, most commonly in what is called fibrosarcomas. Squamous surface of the scale of a fish, and really the squamous surface looks like that. Okay, flash. Lepidic means it's on the surface of the alveolus or a space like this, and it also means scale. or a flat superficial growth. So this is seen typically in bronchial-alveolar carcinoma, a lepetic growth. Okay. Trabeculae. Trabeculae means thick beams. They may be arranged in very broad groups when it is called insular. If they are arranged in serpentine or angulated, it is called festoon. And if it is freely anastomosing, it's called plexiform. So it's a trabecular arrangement which could be insular, festoon, plexiform. Okay. And there are different conditions. Insular is seen in carcinoids. Festoons are seen in neuroendocrine tumors, endodermal sinus tumors. Plexiform in some salivary glands, blood vessels, and liposarcomas, the blood vessels of liposarcoma. This would be, you see, the trabecular pattern, insular pattern, right? Almost like islands, insular pattern, festoon pattern, with the wavy things, okay? And this is the reticular pattern. So these are the different patterns that you see under trabecular pattern, right? Plexiform, of course, is almost like the hair braided together, and then you have this plexiform pattern. In fact, this even in neurofibroma, a gross pattern is the plexiform neurofibromatosis. Indian file. Now see, many people walk like this. You can make out there are many people walking. There are different, and here also, there's many people walking. But Red Indians, they used to walk, especially during war, in a single file. Person one would walk, and the person two behind him would put his footsteps exactly on top of this, and the third one would put on top of this. So to an enemy, it would look as if only one person has walked past. Actually, there would have been hundreds or even thousands walking past. That is the Indian file appearance. Single file appearance is called Indian file appearance, right? And that is typically seen in lobular carcinoma of the breast. Single file of tissue. Palisade. Palisade means a wooden fence, generally enclosing an area. So this is a palisading appearance. They're parallel to each other. Villus means a tuft of hair, and you have this villi, especially in the intestine. Zellballen means a group of cells, cluster of cells, almost like a small packet, and you can get this appearance in, say, pheochromocytomas and other. Immunohistochemistry, you have certain staining patterns, nuclear, cytoplasmic, membranous, and they are self-explanatory. There's a cytoplasmic, there's a nuclear pattern, there's a membranous pattern, and in addition there may be variations. So generally nuclear pattern is seen in transcription factors, steroid hormones, proliferation markers, hepatitis core antigen, and S100. That's typically nuclear. Cytoplasmic, you can see in variety of epithelial markers that you see. Nuclear and cytoplasmic combined, you can get in certain other two things like S100, calretinine, beta catenin. It could be diffuse, it could be membranous, it could be granular, punctate or dot-like CD99 in certain neuroendocrine, and certain cytokeratins in certain tumors, targetoid or ball and chain appearance. So you use these terms depending on how the staining pattern is. They're typical in certain conditions, right? So diffuse, you get in intermediate filaments, contractile protein, secretory protein, melanosome associated proteins. And membranous is most CD320 surface receptors like EGFR, HER2/neu, adhesion molecules like E-cadherin. Granular, you get in mitochondrial or Golgi or lysosomal immunohistochemistry when you do punctate or dot-like when you do a pan-CK, small cell carcinoma, CK in Merkel cell tumors, CD30 in ALCL, and CD15 in classical Hodgkin's. Targetoid, that is a ball and a chain, where you see a little here double staining pattern almost, which is targetoid ball and chain pattern, seen in CD30 for ALCL and CD15 in certain instances. But as you go along, and for example, you'll have various slide sessions with people like Dr. Bojas. She'll tell you exactly which one to accept as good staining and what is the staining to expect in each of these conditions when you go further. So in pathology reporting, one of the problems is the clinician tells it's ambiguous. You use terms which are ambiguous. So ambiguous means the meaning is unclear. It can be interpreted in more than one ways. So when the dog ran out the house, it fell. Whether the house fell or the dog fell, it's not clear in this. So that's ambiguous. So when most pathology reports nowadays will have a bit of clinical details, site of procedure. Diagnosis may precede the gross and microscopic description, or it may be given at the end, and then you can give a comment, right? Usually many prefer to give the diagnosis in the end. So it has to be clear, concise, and consistent, and all the elements necessary for a clinical decision making. No point in writing a flowery language because the clinician does not understand and he cannot take a decision out of the end of the report, right? And in fact, you must have certain comments, and should be in a format which you can retrieve easily. When you search, put a search in your database for certain diagnosis, you get it out. And the quality of information in a report actually defines our competence, how competent we are. Two kinds of report, narrative and synoptic. In synoptic, it's most of the things are given, it's almost like a checklist that you keep ticking and you get the report. Even the radiologists use this form of reporting very often, right? So for example, this chronic hepatitis, you can write chronic hepatitis HCV etiology with a grade and a stage and say which system you're using, or you can write cirrhosis with moderate necroinflammatory activity. It is better than just writing chronic hepatitis, so it gives the clinician a little more. It means almost the same thing, but you're giving that it indicates the cirrhosis. You also indicate this moderate activity, and of course you have given the etiology, and you have given the rest like this similar. So the report should give some information to the clinician which you can understand. We often use various terms, and of which diagnostic of, characteristic of, apparently they are more definitive than others, and many use the term in keeping with and indicative of almost synonymously. But apparently indicative of is more confirmatory than in keeping with. Of course, we all know consistent with is more than compatible, right? And compatible with means if you have seen lichen planus grossly, you also see something which may be lichen planus that compatible, right? Similarly, you must remember probable is much higher than possible. If something is probable, it is more likely than if something is possible. It's possibly a cancer and it's probably a cancer. Probable would be more definite. And people use a variety of terms. There are 37 terms that was seen in a survey of 2 English speaking regions, and it meant a variety of things to different people. But anyway, you have to speak a language which a clinician understands. That's more important. So these some of the definitive terms in a report that people use are here, and non-definitive, you're not here. And uncertainty are is, features are indicative, are in keeping, are comfortable, right? Features are very strongly favor glioblastoma because of this. The diagnosis of glioblastoma is not entirely certain because certain diseases can mimic similarly and so on and so forth. You have to be clear in your report. And it's very important. You will learn how to report each and everything as you go through the entire set of lectures from different people. And many times you'll know that more than the exact reporting, sometimes it doesn't make too much of a difference in the clinical management. That also you'll learn, right? So these are different things that people should be using. So many times you have to take a second opinion, ask for help if you're not understanding something. There's nothing to be ashamed of. Now I'll just come to certain colors. Salmon pink is the color of salmon fish. It is typically orange, not pink, although it's called pink. Okay, and the salmon pink color is what you see in congruent staining in amyloidosis. Right? Apple green is the color of apple green. It's bright green with slight yellow tint, almost like a green apple. And here I must tell you, whenever you do polarized congruent stain amyloid, there are two things. You have a birefringence, which gives the shine, and dichroism, which gives the apple green color. Okay, so there's double green. Yeah. So because different lights are absorbed. Miliary tuberculosis, that's actually a gross term where the size of those lesions are less than 2 millimeters. It's like the millet seeds, they're small grains, and this is seen even radiologically. So not a microscopic term, it is a gross term, right? So this is related to millet seeds. Stools, you could get butter stools when it is steatorrhea, fatty stools when there's excess amount of fat, it's almost like butter stool. Current jelly stools in intussusception is because of blood and inflammatory product, and rice water stools is whitish with certain floccules, typically seen in cholera, and it's seen in serious diarrhea. So this much is for food and stools. You can have spinach stools, right, when there is intestinal hurry. Pea soup stools when it is grayish or greenish or yellow with certain solid material, is almost greenish. That's the pea soup stools. Sago grain stools you get in amoebic. Sago is what is called sabudana for you, right? So you have stools of different colors for your liking. Fish, of course, anchovy sauce, amoebic, and that's the amoebic abscess. That's the color green. Anchovy fish is very expensive, just like salmon. Fish flesh appearance is typically seen in sarcomas, gross, right? A mitral stenosis could be like a fish mouth or a buttonhole. Buttonhole is almost linear like that. Cut cabbage appearance you get in fibroadenomas and also in benign hyperplasia prostate. Cauliflower growth is like a real cauliflower in carcinoma. Other vegetables are onion peel. You get in primary sclerosing cholangitis, in the X-ray appearance of wing sarcoma, sago spleen, get in amyloidosis. Bread and butter pericarditis are two slices of bread with butter inside and pulled apart. So you get this little bit of raised areas or small spicules of butter sticking out, and that's the bread and butter pericarditis because of the fibrinous pericarditis in rheumatic heart disease. Other fruits are strawberry gallbladder, cholesterolosis, prune belly. So you get this almost a crumpled appearance of the skin and underlying in babies, prune belly syndrome. Very aneurysm, get pudy orange, that is the surface of the orange, so much that you get in lymphatic obstruction, breast carcinoma, the surface of the skin. Botrytis tumor looking like grapes, hereditary form mole, there's a drop, almost looks like multiple drops, right? Then you have the salt and pepper nuclei, you have this almost light and dark colored granular nuclei. Nutmeg liver, jaifal that you put in biryani and other things, the cut surface looks almost like this chronic venous congestion of the liver, right? Coffee bean appearance, granulocytal tumor and certain other tumor, typical nuclear groove, right? LCH also you can get this groove. Coffee ground vomiters, so that is because of acid emitting forming in the stomach in when you vomit blood. Okay, and then leg of mutton appearance. It's really like a leg of mutton, osteosarcoma. Chicken fat you get in thrombi, in postmortem thrombi. Then leg of mutton appearance in, earlier there were these dresses which had a leg of mutton appearances. Okay, and it's very interesting that the same appearance is seen in osteosarcoma. So I end with that. So we can have wisdom first by reflection, second by imitation, and which is the easiest, and third by experience, which is bitterest. Please see as many slides as you can, interact with your peers and your teachers and everyone, and learn. There's many things you can learn. Every moment you learn something new, and there are many things even we with so many years of so-called experience we do not know. We are learning daily, and with this I think I'll end, and don't miss to see every opportunity of gross specimens or slides, perform procedures, and enjoy yourself. You have taken up one of the best specialities in medicine, which you'll not regret. You may not get a lot of money like me, but you'll definitely enjoy the subject. You'll enjoy your entire life. So this is where I work, and this is where most of the things that I told you. Thank you so much, and hope I haven't kept you all waiting.
I think, Siddharth, you've done an A to Z or Z of pathology, which started with adenoid, ended with cell balance, and you had lots of things afterwards. I was getting hungry looking at all your fruit and vegetable and everything that you were showing at the end.
Now, medicine people cannot eat, so they don't have an opportunity to eat, so they named everything
so.
after food, I guess.
Yes, I suppose anatomists and pathologists have all these wonderful names for things which they had time, I suppose, to look and to devise names from nature and so many other things. I really think that this was a wonderful tour de force. I think that there are, first of all, I must tell you that you had almost 500 people who were here, 400 and some 89 or 90 people, which I think is good, for the very good, in fact, for what we've been having compared to whatever we've been having in the last few months. So I think that this is really something that people were interested in, and they wanted to learn not only what looks like what, but what are the relationships. I thought it was really wonderful. Then words, from where the etymology of those words were, how do they come into being, etc. So I think that really made it very interesting.
Ma'am, I think the students, they should attend your patterns thing, and they'll really understand the actual.
Well, you know,
this one.
I'm only going to do histopathology.
No, that's what, ma'am. That's
But
more
I think that you have done patterns, gross patterns, which of course I'm not going to repeat. Cellular terminology. You know, it's patterns are made by cells and stroma, but what cells are referred to, I think that was something that you did very, very effectively, Siddharth. I really enjoyed it, and I liked the etymology really very much. So people are giving you a lot of kudos in the chat box.
Oh,
So
see.
you can see that over there, and thanking you, and really there are, you know, the usual claps and other things that are going on. And Anshu in particular feels that it is a revelation, all the things that she learned during the talk. I honestly didn't know anything about the Croton cell, so I learned something from you and from those in the chat box about the Croton cell. I knew about crotonylation of the histone, but I didn't know about the Croton cell. So everybody learns, and I was very happy to you know, listen to this whole thing, literally A to Z. So are there any questions in the chat box, Nisha or Shrutika?
Yes, ma'am. There was one question. Is neuron a giant cell?
No, I don't think that's not counted as a giant cell. You know, giant cell usually, you know, they say there has to be a single cell which is large, other than tumor giant cell. No, if in the normal physiological thing, unless there's some fusion or multiple nuclei, generally people are a little reluctant to call them as giant cells. Neurons are definitely large cells. Ganglion cells are large, but they wouldn't label them as giant as such.
You know, I think there are traditions
Yes.
as to what things are called what. And I think that came out very well when Siddharth was talking, because there are some things that if you sit down, just like the person who asked about the giant cell, and you think, maybe this fits a certain name or, you know, terminology, and we don't use it in that particular for that particular cell or a particular pattern or whatever. And this is nothing to do with science. It's about tradition. And so I think all life has got traditions, whether it's culture or religion or anything else, and professions have tradition. Okay, so I think there's nothing about synovial sarcoma that has anything to do with the synovium, and yet traditionally we have called it a synovial sarcoma, and we just know it as such. So sometimes there's no rhyme or reason, and sometimes there is a reason but there's no rhyme. So I think you know, we just have to learn the language that pathologists speak. It's English, so-called, a lot with a lot of Latin and Greek thrown in, but we just have to learn the language and know how it is applied to the descriptions that we make.
There's another interesting,
sorry. There is, sorry.
There's another interesting comment. Someone had told me that since most of the pathologists are women, most of the terminologies are from kitchen.
No, many of these are given by men. Actually.
Men, actually, yes.
No, but ma'am made an observation even yesterday, no, that there is now the number of men are less. I don't know today how many men and how many women.
We should take a poll next time.
You should take a poll next time, Shrutika.
Yeah, how many women and
we'll
how
do
many
that.
men. That's true. No, but you know that there are, again, by tradition, men and dressmakers. Okay, those who are in fashion are traditionally men. So the greatest chefs in the world are men. The greatest you know, dress designers, and even in India, talk about the most expensive embroidery. Who's doing it?
Abu Sandeep.
So by tradition, you know, the woman might be in the kitchen a lot, but that is for, you know, in the home. There are very few celebrated women chefs, although they are very good at cooking. It's happening. Women are getting more and more empowered, and women are getting out into the world. They're pilots and astronauts. So I don't see any reason why there will not be an overwhelming number of women chefs, or for that matter, women dressmakers, except for people like Veera Wang, and I suppose we have our own Ritu Kumar and several of these. But by tradition, perhaps because women sat at home, were made to sit at home, chefs and the designers, dress designers and other such, were men.
Maybe the women were cooking for the men while they were making observations across autopsies. All right.
I don't know, but it was a wonderful session, as lots of people have said.
Thank you.
There is